So here you're watching drug-induced sleep endoscopy with this monitoring. A 52-year-old male with history of disturbed sleep. His body mass index is 24, so he's not obese. His apnea-hypopnea index is 18, so he's having mild to moderate sleep apnea. Moderate sleep apnea. He has undergone a nasal surgery, as you can see, septoplasty and turbinoplasty already before somewhere else. Now, as we see inside, the nasopharynx is clear, there is no adenoid. The salpingopharyngeal folds are grade 0, they are not enlarged. And as we see here, the upper part of the soft palate is also not collapsing, it's the lower part of the soft palate which is collapsing. And you can see that there is also a collapse of the base tongue. This, this, you can see also there is a collapse of the base tongue pressing on the epiglottis. So base tongue with secondary epiglottic collapse. I'm trying to keep his mouth completely closed. He has been breathing through his mouth in spite of the nose surgery. And if I open up his mouth, let his mouth remain open, the base tongue collapses even more. And if I keep his mouth closed, base tongue collapse is not that prominent. Now, as we try to keep the BIS below 80 and go towards 70, let's see what is happening. The soft palate keeps collapsing. Both AP as well as lateral. And the base tongue collapses but not completely. There's an incomplete collapse of the base tongue. Now it goes into active snoring. You can see a complete collapse of the base tongue here now. Now there's a complete apnea. This is with the mouth open. Now if I try to keep the mouth closed, then we can see that the base tongue is not collapsing completely. Its soft palate is still collapsing. So we have to treat his soft palate and his uh, nose breathing, mouth breathing, because his nose is open, but still he is not used to nose breathing. That's the reason his tongue is going behind. So now when we keep his mouth open, closed, as you can see here, the tongue is not collapsing, but the soft palate is still collapsing. So we have to perform a barbed suspension pharyngoplasty, suspension bridge, because it's majorly anteroposterior and partly lateral. So we'll perform a barbed suspension bridge pharyngoplasty and then give him a chin strap. There's no point performing a tongue-based surgery in this case. As you can see here, now the BIS is below 80. Still the tongue base is not collapsing when I'm keeping the mouth closed. If I keep the mouth open, then obviously everything collapses. Now, this is with the mouth open and the tongue goes completely behind. So we have to keep his mouth closed like this. Once we keep the mouth closed, you can see that everything is open except the soft palate, which you can tackle by surgery. And when I keep the mouth closed, you can see the whole tongue also starts going behind. Complete collapse of the soft palate and the tongue when the mouth is open. And when I keep the mouth closed, immediately the tongue is pulled forward, but the soft palate still keeps collapsing. Once again, this is with the mouth closed and Now this is with the mouth open. This is with the mouth open. And this is with the mouth closed. Immediately you can see that there is a lot of space in the vallecula. So he's a good candidate for suspension bridge pharyngoplasty and chin strap for at least 3 to 6 months after that. Thank you for watching.